Welcome, everyone. Welcome back to those of you who are on our first session. We'd love to have you back. And we're contact lens correction of the irregular cornea part 2. In this session, we'll be addressing keratoconus. We'll also be addressing some of the real specialty designs and fitting in keratoconus with an emphasis on sclerals and custom sclerals. Both of our participating faculty members are renowned in specialty contact lenses. They have both own specialty contact lens practices. They're both advisory board members of the GP Lens Institute, which is the host of this program today. And you'll love the opportunity to have patients, and through the courtesy of Dr. Stephanie Wu, who has her private practice in Las Vegas, Nevada. And then we certainly love the input of Dr. Elise Kramer and her practices in Miami, Florida. But welcome to all of you. We have just a couple of housekeeping items, just a reminder to get CE credit. You would be on at least 50 minutes. If you want to ask questions, that Q&A button is where you want to go. Last session, if I didn't get to everyone, I apologize, and we're going to try to leave. That'll be my job this hour primarily, is just really trying to get as many of the Q&A as we can, and then also have a few minutes at the end for people who have questions right at the end. So welcome, everyone. We're excited to have you tonight. Here's my affiliations. Here is Dr. Wu's. And here are the disclosures from Dr. Kramer. So just to tell you a little bit about what we know about keratoconus, and some of this probably relates to some COPE questions that we provided. Everybody knows it's bilateral and it's one eye progresses before the other, and there's exceptions to every rule, but basically that's it. The initial changes are in the stroma. The pathognomonic signs are Vogt stria and Flesher's ring. Munson's sign, the protrusion of the cone to the lower lid is when they look down, is a late stage sign. One of the best theories on keratoconus is by Christina Kin, and her cascade hypothesis saying that patients susceptible to keratoconus are unable to produce the necessary enzymes to reduce the free radicals within the cornea, and they accumulate, and that becomes toxic to the cornea, and that leads a whole cascade of events in terms of what we characterize as keratoconus. It's initiated and aggravated by mechanical trauma, i.e. eye rubbing and exposure to UV light. So there are people who have the tendency for keratoconus, and your patients should know it's not their fault. They likely were born with that tendency, and then it was activated. We talked about this in the first hour, but there's different types of cones, and this is from the CLEX study. And the nipple, which you see on the right, is a small cone that we talked about small diameter lenses being optimum with. Oval are kind of the intermediate size. Globoid are large. They predominant size of the cornea is red when you look with topography. The marginal cones are the inferior displaced cones, several millimeters displaced inferiorly. Today, we may not have a hybrid patient who made it in. The emphasis today, we talk about hybrids, but the emphasis today will be on sclerals, and it's going to depend on you. I'm not going to steal Dr. Wu's thunder, but you'll have some input on what you want to see later today. When hybrids, we talk about in keratoconus the ultra health, which for those of us who have as much gray hair as I do, we started with the Saturn and the soft perm lenses back in the 80s, and those lenses, of course, very low oxygen, very tight fit, very easily ripped. We've made huge advancements in terms of hybrids, in the sense that we have a hyper decay rigid, we have a psi-high skirt, and the lenses are almost impossible to tear. We still have to monitor for tightness, but overall the improvements have been remarkable. These are the conditions that oftentimes we think about a hybrid, irregular corneas, corneal GPs wanting better comfort, piggyback patients who don't want two lenses in their system, and any of the cases, mild to moderate cases, that really would not benefit or like the other options that are there. There are, with the Ultra Health, 11 different vaults, kind of the equivalent of base curves, but how much it's going to vault the cornea. and 4 different peripheral skirt curves. And you can see those here. You want these lenses to vault the eye. That's important. Typically, as you'll see in this OCT, you're looking at about 50 to 100 microns of clearance with an ultra health, and that's certainly desirable. When you look at the lenses, for example, in this particular case, there'll be a recommendation for your initial lens, and then you can look at it. You can use fluorescein. If you have that seal off, like you see over left, then you're thinking about less sag. If you see bearing, then obviously we're going to go to a higher sag value, and they're in 50 micron increments. This is what you would like. You've got clearance, definite clearance, really a nice fit, and that's what we think about typically with an ultra health. And it's an important tool to have in the toolbox. But the tool that really is getting used so often is the scleral lenses. And thank God I lived long enough to be able to fit those and be in a position to really understand what the benefits of these are. They have similar initial comfort to a soft lens. And remember being in practice, and all we had were small diameter corneals, and there would be patients ultimately that couldn't tolerate them and ended up having a transplant. We had a corneal specialist who was very happy to do that, but now I just think of all those patients that could have had a scleral. The biggest categories of mini sclerals, the 15 to 18 millimeter ones, and those of course will be the ones we'll emphasize in a little while. We use them predominantly for the irregular cornea. The SCOPE study had a mere 84,000 fits that Muriel Shornack and her team got data from. 16% were fit for ocular surface disease. And when you think about it, it might be the only contact lens we have for the severe dry eye disease patient. And then about 10% for your multifocal and astigmatic healthy eyes. Every year when we do the GP update article in contact lens spectrum, I'll poll the readership to go kind of what's your go-to lens for your irregular cornea patients. And if you look at the right column, the greater than 50% of their irregular cornea patients, over 50% of the practitioners, that was their go-to lens. And then small diameter intralimbal hybrid and so forth. So yes, sclerals have had a huge impact. In fact, when I surveyed our advisory board to put this information in that GP annual report, Dr. Kramer, Dr. Wu, and everybody else responded that the top 4, these were the top 4 in decreasing order of what they felt like were the biggest advancements in 2020. First was stable wettable 200 DK materials, and really the first 3 were pretty similar in the responses. So we'd be talking about Optimum Infinite and now Acuity 200, profilometry, topography driven scleral designs, of which you'll have plenty of information provided at our meeting. And we've got, tomorrow we've got a keratoconus super session. Saturday we got super sessions on myopia and sclerals that you're really going to enjoy. So, and then custom back surface scleral lenses. And the 4th was, which I was kind of excited about, new disinfection guidelines were one of the factors, and I'll get to that in a minute. Oh, I'm going to skip through that because I hear his voice. There's 2 studies really have looked at corneal transplants, and the first one found 40 out of 51 eyes that would have gone for transplants were avoided with a scleral lens. This one in cornea, which just came out, found that the final recommendation was that those, and this is based on 2,806 eyes that had keratoconus rictasia, they found that those who successfully wore scleral lenses or corneal GPs have almost 1/5 the risk of undergoing keratoplasty, and that's huge. So our goal again with sclerals, we don't want them sitting on the cornea. We don't want that mechanical trauma. So we definitely want them to vault. And this shows you a good example of not only vaulting centrally, but also the limbus, and then landing or aligning with the sclera. And then good limbo clearance as well. And those of you who have the benefit of having OCTs can, check out where the edge is and whether it's resting on the sclera or if it's fitting tight and embedded into the sclera. And I'll finish with just some of the resources that we have, helpful organizationally. These are the groups that really have a lot of information for the contact lens management of the keratoconus patient. And I'd recommend all of them. They all have their strengths. They have on their website, especially if you go to gpli.info and go to education by lens type, there's where you get about all of the information you need, and that in the webinars. Lens resources, the Scleral Lens Society is awesome. They have workshops, webinars, and they have great videos on lens care and handling. GPLI has 27 archived narrated webinars, and with the SLS, they have a scleral lens troubleshooting mini book. And then the other resources that you see down here below. I mentioned the videos for the Scleral Lens Society, awesome for teaching insertion and removal. And then the fit scales, if you just Google Michigan College of Optometry, you can get the Scleral Lens fit scales. And if you don't have an OCT, this is really helpful to evaluate how much clearance you have and also evaluating the periphery. And I'm going to put a plug in for this, since Contact Lens Spectrum is our sponsor. Scleral Lens, the Scleral Lens Primer article is a very comprehensive A to Z article for people interested in learning how to fit scleral lenses. The lead author is Jason Jedlicka, and it's online in the October issue of Spectrum. And finally, I mentioned about disinfection. Christine Stent had a huge interest in trying to come up with standards for disinfecting soft hybrid and GPs. So we got a team of leaders from the AOA and Academy sections, and this is published just a few months ago in Optometry and Vision Science. But we kind of dumbed it down into a laminated card that you can have in your practice in terms of disinfecting your scleral lenses after you've used them, because you're going to reuse them. So this is the information that you would need to know. And again, you can get it right through the website on GPLI. So with that, I will turn it over to the star of the show. That is Dr. Stephanie Wu.
How do I make this? How do I move this? Just to show the full screen. Oh, good. Here we go. Awesome. So,
just so everybody realizes, Stephanie is in her practice able to have a PowerPoint with the cases and then also have live patients. So it's quite a bit of technology.
Great. So hope everybody can hear me. If you can't, then, well, I guess they wouldn't be able to tell me if they can't. But just wanted to say welcome everyone to the Contact Lens Institute of Nevada. And just for, Elise, can you tell me if you hear me?
I hear you.
We hear you. We hear you.
Yeah.
Okay, perfect. So welcome to the Contact Lens Institute of Nevada. I am Dr. Stephanie Wu. Super excited to be here with you all today. Not sure where everybody is coming from around the world. Super excited to be able to share some of these cases with you guys. I want to get to the very first question and most important question of the evening from Dr. Dave Geffen about which wine I'm drinking tonight. And luckily for the patient, I haven't had any, but depending on how this session goes, that answer will be different later. But anyway, I just wanted to say thanks so much to the entire team here at the Contact Lens Institute, Dr. Wong, who's here assisting with our patient, Britt, the cameraman, and then Taylor as the office administrator. Of course, thanks to our amazing patient, James, and we are going to go over his case now. Okay, so James is a 35-year-old white male. He has worn preference toric lenses for years, and he's got a history of very high cyl and keratoconus suspect. He came to us because he felt like his current soft lenses just weren't quite right. He was experiencing vision that he just thought was kind of suboptimal and just kind of frustrated with his current vision. So these are his topographies, and when you look at them, of course they look very normal. This looks like a very classic corneal cyl case to me. When I look at this this topography, I would not suspect really keratoconus, or he would be kind of lower on my radar compared to most of the patients we see. This looks like a very typical astigmatism patient. However, some of the things that end up happening is that when you've got these keratoconus patients or patients that have decreased vision, those are sometimes things that we have to look at. So in this case, he's got a lot of cylinder that's actually more than the corneal cylinder that shows up on his topography. And he really only sees about 20/30 in his glasses. With the slit lamp, he doesn't have any stria or thinning that we can see. So Dr. Kramer, I'd like to get your opinions on, with this patient, with this history of wearing his soft lenses, things like that, what are some of the diagnoses that might be going through your head, and what kind of lens options would you consider for this patient?
So one of the things that obviously I think keratoconus would come to my mind, not based on the topography, like you said, it has that bow tie pattern. It's a little suspicious though. I mean, if you look at it carefully, you can see it was steeper inferiorly, but one of the things that really strikes me here is the visual acuity. So obviously, if the cornea is regular, the visual potential, if you rule out anything else going on in the eye, should be 20/20. So the patient's not reaching 20/20. I mean, you could think of amblyopia because of the level of astigmatism. So, I mean, there's a lot of differentials here, right? But definitely amblyopia, keratoconus. And then another thing is if they've been wearing toric lenses for a long time, a lot of really toric lenses, like with high astigmatism, can actually cause warpage, corneal warpage. And so that would be on my list as well. And so, there's a lot of options here. And we just got a comment about retinoscopy. That's another useful test that you might want to use in this setting as well.
I have to agree. If I can jump in, I totally agree. I thought the comment on retinoscopy is perfect, and that's how we always used to diagnose it before topography. Is you got that scissors reflex, because that, when you look at this patient, just the information we have, you start thinking with the rule cyl, high, no Vogt stria, Flesher's ring, none of the pathognomonic signs. So this isn't keratoconus. But if you get that scissors reflex, and then also if you're seeing changes going on, over time, especially if it becomes a little bit more, it seems to be fairly with the rule, but if it begins to change, then, I think Dr. Kramer is right. We may be headed toward the keratoconus area.
Yeah, so I agree with both of you guys. I think sometimes the treatment options are similar depending on if they've got normal cylinder or if they've got irregular cyl, if they're keratoconus suspect versus not. The good news is we have so many different tools in our toolbox to select from. And I think that James would be a good candidate for many different things. The good news is we've got amazing laboratories that we work with, and they were kind enough to donate lenses for this workshop for us. And I just wanted to kind of go over what we ended up doing. So we ended up fitting this patient into a scleral lens just to kind of see what would happen. And not only a regular scleral lens, but we did something called the Latitude, which is a custom scleral lens. So what happens is we take some 3D images, and you can see in this picture where he looks straight ahead, he looks up and down, and then this scleral topographer actually stitches all of the images together, and that's how we come up with a custom designed lens. This is a picture of if we put the lens into kind of this design software, kind of what we're seeing. I think it's kind of interesting. We're looking at the nasal aspect, the superior and the temporal. And you can see on that nasal aspect, there's a little bit of an elevation there due to a small pinguecula. And this is such fascinating technology nowadays, because in the past, we didn't have this type of technology. So we kind of had to troubleshoot the fit and just keep making changes to standard lenses before kind of going on to some of these more untraditional approaches. And Dr. Kramer, I would love to get your comments on what are we looking at here? This is when we stitched the images together of his eye. What are we looking at? What kind of, because it kind of looks like a topography, but it doesn't look like a traditional corneal topography. What are we looking at?
Right. So this is the elevation map. You have the corneal and scleral elevation. And so what you're doing here is profilometry. So you're going beyond the cornea and you're mapping the sclera as well. So this technology gives you information about the sagittal height of the eye you're fitting. So a lot of useful information for fitting lenses. So you can see here in areas that are more red or warmer colors are actually lower, and the areas that are green, that are blue, are higher on these elevation maps.
Mm-hmm. Excellent. And something that one of the other doctors had pointed out, I posted this picture on my Instagram, and he had asked, it looks like the scleral topography is very similar to the corneal topography as far as the pattern and kind of where the steepest areas are. And I know that there is some research, and I couldn't find the exact study that kind of showed if corneal cylinder is matching up with scleral cylinder. And Dr. Kramer, what are some of the most recent articles that have kind of come out as far as research goes?
Yeah, so there's a very interesting study by the Scleral Shape Study Group. And they came out with information showing that there was some association between corneal and scleral topography. It's actually really interesting, saying that the closer to the limbus, or the further from the center that the cone is, the more likely you will have a toric or asymmetric sclera. And the more central the cone is, the less likely, or the more likely you'll have a more symmetric sclera. So that's really, really interesting and very important also when fitting scleral lenses.
Well,
Yeah,
and if I can make a comment, I exactly, and I think there's, what's really neat today, and both of you have those tools, you know, when you're able to look at the posterior cornea, you're able to look at, you know, the profilometry, you know, be able to see the toricity of the sclera, and, you know, those are helpful, not only in terms of the type of design you're going to use specifically in sclerals, but also what type of lens in general you would use. Again, when I looked at the initial topography and all that, I'm thinking bitoric GP. I'm thinking, well, fairly symmetric. But you have the tools to really be able to look at it in greater detail to see if, in fact, you know, there's more going on here, and there's more asymmetry or more toricity. One question I'll ask is, one of our attendees asked, did this patient have dry eye syndrome?
Yeah, so he does suffer from some dry eye, which you're actually going to see when we look at his slit lamp video in a few seconds. He does have some fogging issues and some debris in the chamber that we'll look at, but he does have some dry eye as well, which is also kind of a reason why I think some of the contact lenses have not worked optimally for him. So we're going to kind of discuss that as we kind of move along the case.
Also, another comment I want to make on the scleral topography here or elevation is that you see that it's not symmetric all the way around. And so that's really important to take into consideration when designing the scleral lens, when designing especially the edges and the landing zone. Because if you use a symmetric lens, a rotationally symmetric lens, then you may have complications in a case like this.
Yeah, absolutely. And I think these types of instruments have really given us that information that we would have never known. You can't get this information with really any other tool on the market besides maybe putting a diagnostic lens on with known parameters and then kind of trying to troubleshoot it. But having this type of instrument to be able to guide us, it has saved me a tremendous amount of time. And it's really helped to dial in the fits rather quickly. And I remember, Dr. Kramer, you had this instrument before I did, and you were the one that said, you should really look into it because it's really helping to kind of expedite the fitting process. The fits are more accurate kind of right off the bat. And those are some things that I have definitely seen throughout my fitting experience with the S-mount. So this is, I thought, a really cool video. It just kind of shows kind of going around the entire eye and how the shape of the lens changes. And Dr. Kramer, I'd love to kind of get your comments on what are we looking at? What's going on here with this video?
Well, what you're looking for is a lens that's going to be clearing over the entire central part of the cornea, because you can have very irregular corneas, advanced keratoconus or transplant, and you want to make sure that regardless of how irregular it is, that you have even clearance throughout the entire central part. And that's what this video is showing. It's showing how well this lens is simulating to clear over this cornea, even though it's very irregular.
Awesome, thank you. So we did the same thing on the left eye. So basically we wanted to get him into a bilateral pair of Latitude custom scleral lenses. Same thing, just did all the 3D imaging, and then the lab used all of their stuff to design the lenses for us. So this was a video of his right and left eye on dispense. So you can kind of see that the lenses are moving a bit, and things were a little bit uncomfortable for him. He was getting a little bit of lens awareness. But if you look at the edge of the lens, it looks so good. You can see like all of those little blood vessels are going right underneath the edge of the lens. It's looking quite good as far as the fit goes right off the bat. And Dr. Kramer, I just wanted to ask you, when you see this type of fit and it's moving just a little bit more than you would like, do you normally just let it be and then reassess in a couple weeks, or would you make a change right away?
There's a lot of factors to take into consideration. And one of the things that I would do, it really depends, because the lens is going to settle with time. So it depends if you're looking at this lens after 30 minutes or if you're looking at it after 4 hours. So that makes a difference. And I think also what's important to find out is how the patient feels, because you can have a lens that, we were talking about this in the first part and how we want things to be perfect. But if the patient feels great and the lens is pretty good, then you might not want to change anything. Of course, as long as you don't have severe impingement or, anything like alarming, then you might be able to leave it alone, depending how the patient feels.
Awesome.
What's really impressive is just the technology. When you think about the eye print molded lenses, what the technology behind Latitude, be able to look at all dimensions and be able to come up with a lens that really can align with about any eye begins to tell us that maybe there's not anybody on this planet with a diseased cornea who can't be fit into a contact lens. Before we go into the second dispense, Dr. Wu, there was a question talking about the opinion that this individual felt like it was regular astigmatism with a very old contact lens design. Keratoconus is out of the question in his mind. At 35, the keratoconus would normally have stabilized. So no worsening should have happened. Warpage is the most likely culprit. A much higher DK soft toric or a much simpler scleral lens could have been fine with a toric, with toric haptic, maybe a notch. What do you think about that?
Yeah, those are good questions. So in this patient in particular, he could fall into a million different contact lens options. We could do a custom soft lens. We could do a bitoric corneal GP. We could do a hybrid lens. We could do a scleral lens. We really could go on and on about the different options that we had for him. The reason we chose this lens is really we wanted to see kind of what happened for the workshop, first of all, because we wanted you guys to be able to see an interesting patient. Plus, with his job and everything, he really wanted to have very stable optics and things. So we just thought, let's just try it and see what happens. And if he doesn't end up doing well with this design, we can always do something else. But I don't think that there's a right or wrong reason. This patient would probably do really well with a bitoric lens or a custom soft lens or even a hybrid lens. It just kind of depends on what you feel comfortable fitting, what the patient is comfortable being fit in. If he was somebody that had already tried a corneal GP a long time ago and he hated it for comfort reasons or it popping out, things like that, maybe you would go down a different approach. But there's really no right or wrong answer to these types of cases. It really just depends on you as a practitioner and the patient's history.
Well, and I'll make one more comment and I'll be quiet, but I think latitude is not a bad option for this patient. And I'll tell you why, because yeah, maybe you could go to a different type of scleral, that's possible. But with the amount of refractive sill, a soft toric, you're not have to worry about the edema, but you do have to also worry about, rotational effects with that much cylinder. So I think when you're looking at that, I think it is a viable option.
And
Yeah.
one thing I want to mention about warpage is that you might not get a clear bow tie pattern like we saw on the topography. It may look more irregular and asymmetric from one eye to the other. So really the only way to know is to wash out the patient of contact lenses. And sometimes some patients are not willing to do that, especially with a high level of sill like that. So it's hard sometimes to differentiate.
Yeah, absolutely. So basically we contacted the lab and we kind of told them what was going on. And so they sent us another pair of lenses, which is what we're going to look at now, where they tightened up the peripheral curves a bit to help with some of the lens movement. He also is complaining of lens fogging as well. He's been using Oasis tears and preservative-free saline to fill the bowl of the lens and putting that on. When we took a look with the slit lamp before we got on this webinar, we noticed that the lens is still moving a little bit more than I would prefer. And he's had the lens on for like 5 or 6 hours. So it's a really good fit to kind of look at so we can talk about troubleshooting. Because sometimes when you do some of these workshops and you just see perfect fits all the time, you don't learn a ton. So I'm really excited for you guys to kind of see a real live patient. He's complaining that the lens is still a little bit foggy, having a little bit of lens awareness. And so let's take a look at the lenses on his eye and kind of go from there. All right, so Dr. Kramer, what are you noticing right off the bat when you look at this lens?
I mean, I really doubt this patient is going to be comfortable. There's just like an excessive amount of debris behind there. You can really see it and it's moving. There seems to be definitely, that's a red flag for me right there.
Yep. And the lens, I think, is moving a lot more than I would like. So I think when we reorder the lens, of course, we'll send the videos to the lab so they can kind of help adjust for some of the movement. Any other changes that you would make to the actual lens? I believe he's in Optimum Extra with HydraPeg currently.
I mean, hydropeg would be more for a surface issue. Yes, it would be useful. But to get rid of that debris just under the lens, I would look at the edge. There could be, in addition to movement, it could be that the edge is just lifted a little bit. And so it's hard to appreciate here without the 3D, but you'll tell me if there could be some lift there, and that could be just allowing a lot of debris to go underneath.
Yeah, I don't have the OCT images up because we haven't done it on him to date, but I believe when we did the dispense, I don't think there was any edge lift there. So
Yeah.
but that's definitely a very, very common problem.
Yeah, and then, there could be other reasons for debris, and obviously ocular surface issues, blepharitis, anterior blepharitis. So those have to be resolved as well.
This would be a good opportunity to mention that the tangible hydropeg boost solution is going to be available starting next week. And for a lot of the scleral lens wearers, the dry eye issues, the coating, wettability issues, you really do want to pay the extra fee to have them hydropegged and be able to have a good wettable surface. The boost solution will be a monthly solution. It's a prescription solution, but it's a monthly solution that patients will be able to refresh the coating so that the lenses will definitely last longer. And that'll be very good for cases like this. We had a question, Dr. Wu, saying, what is the margin of error for custom scleral lenses? Like in this case with the latitude, part of that might be refits.
That's a great
whatever.
point because most of my latitude patients or other custom scleral patients or impression-based patients, their fit is usually quite perfect within the first or second lens. So this is actually kind of an oddity as far as all the patients that I have in custom scleral lenses. Usually the fit is quite good with the first or second lens. And of course, Dr. Kramer can comment that as well. But yeah, that's a great question. I will say that the getting to the end point is a whole lot faster when you're using some of these custom and innovative technologies compared to just a standard diagnostic set. So yeah, Dr. Kramer, I'd love to hear your results too.
Yeah, and sometimes it's a one shot and done, like on the first dispense, and those always impress me because that was like unheard of before this type of software. But sometimes it does still require some tweaking. I think your final lens is a lot more stable and probably customized than what you would have had otherwise. And so that's definitely beneficial for a lot of our patients. But in terms of margin of error, it's really case by case.
Two quick questions, Stephanie. One is, and I'll just say them both. Have you tried Neutrophil to fill, as a filling solution? And secondly, do you know what the tear lens depth or what, the vault is centrally?
Yeah, so the vault on both of these is around 200 microns, which is for me quite perfect. I know a lot of doctors have their particular vaults that they prefer, but 200 for me, especially after wearing the lens for an hour or longer, I think is great. And yes, he's tried Neutrophil, Oasis tears to fill the lens, different solutions, things like that. So I don't think it's a filling solution issue. I think it's more the lens fit just needs to be adjusted a hair, and I think it will help tremendously.
Mm-hmm.
Yeah. So if Dr. Bennett, is there anything else that you would particularly like to see on this patient, or any other questions relating to this patient or technology that Dr. Kramer and I can answer?
No, I think the technology of maybe a poll question might be a good idea.
I like your thinking. All right. So let's go to our fun poll. And Yeah, so basically we've got a couple other case studies, and we just wanted to find out which one would interest you more. And so just give a few minutes to kind of respond, and then we can see what everybody wants to do.
While that's going, Stephanie, we did have a question about, do you paint the surface with sodium fluoride to attempt to see where the debris is coming from?
Yeah, that's a really good point. A lot of times if we're not sure what's going on with the fit, or we want to evaluate the fit, I like to paint sodium fluorescein on the top of the lens and then evaluate it really quickly and take a video and see where the lens, where the fluorescein is seeping in from. Because sometimes, most commonly for patients that are having issues either with the fit or with some debris or lens movement, it's because there's some extra edge lift in different areas. And that's a really good question. Dr. Kramer, what do you do?
Sorry, I lost my connection for a second. Yeah, I feel the same way. I would agree with you on that one, Dr. Wu.
Awesome. Okay, cool. So it's a pretty, almost a tie here on what we wanted to see, but it looks like most people want to see the corneal post-graft lens fit, which was our corneal transplant patient. So let's get back to the PowerPoint here. Okay. Okay, so we are going to talk about a patient that we recently saw. So this is it's an interesting case. It's actually one of the more difficult cases that I've worked with. He's a 79-year-old white male, and he's got keratoconus, and he wore corneal gas permeable lenses for many, many years. He did end up, like a lot of keratoconus patients that have been in corneal gas permeable lenses for a long, long time, he did end up with heavy, heavy scarring, and he needed to get a corneal transplant for the right eye and the left eye. He also developed glaucoma in both eyes over time with very, very large blebs. These things are gigantic, probably some of the biggest blebs I've ever seen in my career. So right off the bat, I kind of think, well, he's got a corneal transplant. He's got these very long blebs. So we've got a lot of things that we've got to look out for. So this was a topography of his right eye, which is the eye we're fitting. And I would like to ask Dr. Kramer and Dr. Bennett, given this patient's history, he's worn GP lenses a long time ago. He had a bilateral transplant in both eyes. He's got glaucoma. What kind of lens options are you thinking might be appropriate for this type of patient?
It's hard to jump to a scleral lens just directly in this case because there's a lot of factors. The corneal endothelium, you want to get a good cell count, then there's the glaucoma and the potential risk of an increase in IOP plus the blebs. So there's a lot of factors here. But if he's already worn GPs in the past, didn't like them, then I would obviously lean more toward a scleral lens in this case. But that's definitely not the only option.
Yeah, I think you look at this and you do, sclerals are an option because there's a little bit, I don't want to use the term train wreck cornea, but, there's certainly a tremendous amount of irregularity, but you also, you always think about in transplants that can you be successful for, with a large diameter corneal? And is that something that you can, with a reverse geometry or some type of permeable cornea? And so that's would be my tendency, but knowing that sclerals are an option.
Yeah, and I think that you guys are both spot on. You guys have so much experience with these types of lenses, and with corneal transplant patients, we have to be so careful, especially people that have blebs or they've got other coexisting conditions with their transplant. So it's a very, very delicate situation. I tend not to jump right to a scleral lens for corneal transplant cases, just because their eyes are so delicate and fragile, and you have to really worry about the endothelium. They require lots and lots of attention and detailed follow-up care. So for this patient in particular, we decided that we wanted to fit him with a corneal GP lens. So first, we tried the ACE lens. This is a lens that it's an eccentric lens from Art Optical with a 7.2 base curve, 9.5 diameter. Again, I just picked a lens out of the fitting set and popped it on according to the fitting guide to see what happened. So Dr. Kramer, Dr. Bennett, I'd love to get your thoughts on this fit. What are we seeing? What are your thoughts right off the bat?
I think that's a pretty good first initial fit. It looks like it has a nice lid attachment. There's a little bit of touch inferiorly, but overall it's pretty good.
Yeah, I agree. I think it's it's going to go a little bit toward the apex, but overall, meets my number one criteria. It's staying on the eye, and there's decent edge lift. So yeah, I would agree with Dr. Kramer.
Great. So I always like to try a few different things. So went from a 7.2 base curve to a 7.0, and so just by steepening up a bit, we get a pretty different fluorescein pattern and different lens fits. So Dr. Kramer and Dr. Bennett, what are you guys thinking on this one now?
Well, it's definitely sinking a little bit lower. So the other one was a little bit better centered. This one seems to be going down. And it just doesn't seem to be fitting as well as the previous one.
That's interesting, isn't it? After the blink, that it almost has like an against the rule fluorescein pattern, which is kind of interesting. I think you can tell you went steeper, that's for sure. But I agree. I think the decentration is more problematic with this, and sometimes you can have a little better pickup with a flatter lens.
Yeah. So basically, the next lens we tried, we just decided, long story short, the lens ended up tightening over time, even though the fit was really good. So we ended up jumping ship and getting rid of that lens design completely and starting over with the Rose K post graft. And I know that you both know a lot about this lens design. This one felt a lot more comfortable for the patient, and his vision was a bit more stable. So I just wanted to get your comments on what you guys are seeing here.
Yeah, I'll just say that, again, maybe concerned a little bit with the edge lift. You know, that you can kind of tell that on after 10 minutes. But I think, you know, overall, it doesn't seem to move excessively, just has those areas of excessive edge lift, almost like it is kind of, you wouldn't expect that on a steep fitting lens, but it's the cornea irregularity that's causing all that. So I think from a movement standpoint, it looks good. And I think it's good going to a post-graft lens. I think every lab has at least one or two. So, you know, I know you'll be close with your lab consultants to work through these kind of patients, but yeah, just concerned probably about what's going on in the periphery. What do you think, Dr. Kramer?
Yeah, I think it's not bad, like considering how irregular that cornea is. It's pretty well centered, you know, not the ideal fluorescein pattern, but it's really not bad.
Great.
Yeah, you know, interestingly enough, if you go flatter, you're probably going to bring that edge out even more. So that's a good example of where it's kind of hard to get perfection unless you glue the lens on the eye. So I think that there's a lot of really good, happy patients with fits like that.
Yeah, so in true Dr. Wu fashion, I emailed all of the topographies, the different lens fits and videos to the lab, and the experts at Art Optical, the consultants there, they helped us kind of redesign the lens. And this is the 7.0 base curve we saw, they wanted to go just a hair steeper. Then we just added in the 250 power, and then they just changed the edge lift a bit. So this patient is, he hasn't made it back in because of COVID. He hasn't gotten his vaccine yet, so he probably won't make it in for a couple more months. But I will be certain to give Dr. Bennett a updated video file after we see the patient for his dispense.
All right, we have a couple of questions, some good ones. And I assume the post-graph, this is for James' question, I assume that was a reverse geometry design. But the one question that's interesting, and I'll tell you who wrote it, and that makes good sense, is Karen DeLoss. Can you talk about your fitting algorithm for post-PK, your post-PK starting lens? I mean, do you look at 4 millimeters temporal to the central K, one of the common philosophies? Do you start, at a certain amount flatter or steeper than K?
Yeah, that's a good question. So I think it depends on the fitting set, because a lot of them have different approaches and kind of how they want you to start. And then it also depends on the type of information you have on the patient. So if you knew kind of what their corneal shape was and their history kind of before they got a transplant, that can also be really, really helpful. In this case, I had just seen him for the first time after he had his transplant for quite some time. So I didn't have much data on him beforehand. So he's a new patient to me. But in this particular lens, I believe you look at the difference between like the graft host junction. And I think that's where I ended up starting, and that's where I ended up with that first base curve. Dr. Kramer, do you have any advice or things? Where do you start?
Yeah, I agree with you, Dr. Wu. I think it's important to follow the guidelines by the specific fitting set that you're using. I usually like to kind of go near the K, depending on, again, it's so case by case, but and then it's a lot of trial and error. It's putting on a lens and seeing how it behaves, and then making changes based on that. Obviously trying to get the best fit in office will reduce, further chair time when you're dispensing.
And this sounds so kind of silly, but as you fit these lenses more and more, you kind of know, you get like a gut feeling, or you get kind of an intuition on what lens to pick first, like when you fit these so many times. And I know, Dr. Bennett, you probably aren't even aware of it because you just do it so much. But I know that the more and more you fit of these types of lenses, you get like a groove, you get like a comfort zone, and you kind of know, you have like a feeling in your stomach that, like, you know what, I'm just going to start with this lens because I kind of know how this lens operates and how the fitting relationship, because I've seen it so many times on so many different corneas. And you know, like I said, Dr. Bennett and probably Dr. Kramer too, you guys do so many of these. You almost get like a gut feeling of what lens to start with after you do them a lot.
Well, I think in a past life, and that's all we did fit on post grafts, were kind of large diameter, you know, corneal lenses. And so you kind of, when sclerals came along, then, you know, they certainly are an option. You just have to be a little more careful. That it's all the comments made about fitting large diameters, I think still hold a lot of truth. There's a few questions. I know we've got about 5 minutes. What's your opinion on fitting ultra health lenses on post grafts?
Yeah, so the Ultra Health FC is designed for some of those oblate corneas. I don't think I have any in particular. Most of my FC patients are RK patients or post-refractive surgery. And that's just because sometimes what I have found with the FC is, with a couple patients that I fit, is sometimes it will, the junction of the graft host kind of can rub on that outside of the GP lens and it can tighten down. So I don't have much experience with those, but I'd love to hear from Dr. Kramer if you have some.
Yeah, I think you can probably use a hybrid on a lot of these cases. But it really depends on the type of cornea you have. So after corneal transplant, you can have very prominent, in those prominent graft cases, or you can even have some more oblate shapes. So that's important to look at when fitting a hybrid lens, because obviously that's going to determine the type of lens that you go for. But you can have success in these cases as well. And sometimes you need to, because maybe a corneal lens is not working, a scleral lens, you have the blebs. So maybe a hybrid lens could work in a case like this, rather than a scleral lens.
Okay, a couple quick questions. One for you, Dr. Kramer. One of the attendees said, would you kindly share a link to the study comparing scleral versus corneal profile relationship?
Yeah, I can definitely.
You can send that to me. It's a good friend of mine who asked that, so you can just send it to me.
And actually, I think I saw Dr. Danair in this webinar with us. So maybe he's actually one of the leaders on that study. So maybe you could share it in the chat if he has it handy. Otherwise, I'll email it to you for sure.
Is there a slit lamp adapter for iPhone that you found to be the easiest to use in transferring clinical data to the lab?
Yeah, so I have one called the Ion system, and it's basically an iPhone that's connected to the slit lamp, and it's great because I can just take videos, I can take images, and then because it's an iPhone, I can airdrop a lot of things to my own phone if I need to, or it could be downloaded quite easily. There's also a lot of software and systems out there, and maybe there's some that are featured at this meeting, but I would definitely advise either getting in touch with some of the reps or getting a demo. And unfortunately, with these live events, you usually be able to go to the exhibit hall. But if you're looking for something super cheap, there's a few online you can just Google. I know, Dr. Bennett, you had mentioned that in the beginning of either this session or the last one, but there was one in optometry school. It was called Tiger Eye, I believe. I don't know if they're still out there, but it was less than $100, and you basically just kind of snap it into your cell phone, and then you're able to just kind of take photos and images there, and then you can easily email those to the lab.
All right, awesome. I think for time, we have 2 questions, and we'll just make them quick, and then we'll wrap up. You guys, again, have just been awesome on your questions. how do you check for edge lift in the superior and inferior meridian on a scleral lens?
Yeah, Dr. Kramer, I'll have you answer that.
Yeah, so if you're taking pictures